Live from Atlanta, I'm Emilio Madrigal, and I'm remotely joined by my colleague Rafat Manan. Today, we are excited to host Dr. Andres Matoso from the Johns Hopkins Hospital to present his digital slide seminar, Mesenchymal Kidney Tumors. We hope everyone had the opportunity to preview the 10 whole slide images that were provided for this lecture. And I want to quickly mention the Pathology Education for Clinicians website from the Department of Pathology at Johns Hopkins, and which offers numerous educational opportunities, including unknown case conferences, iPad applications, including the one that we featured just recently, the Pancreatic Pathology by Dr. Ruban. You can also find links to previous pathcasts. And while there, please make sure to join the email list to hear about new pathology iPad apps, pathcasts, websites, and other educational materials offered by the Johns Hopkins Pathology Department. As always, you are more than welcome to ask questions by typing them as comments right here in the Facebook Live and YouTube Watch pages, and we'll make sure to pass those questions along to Dr. Matoso at the end of the session. And as many of you are aware, Dr. Matoso also speaks Spanish, so if you wanted to post questions in Spanish, please feel free to do so. So English and Spanish are welcome. So with that, I will now turn the microphone over to Dr. Matoso.
Hello. Well, thank you everyone for joining this lecture today. It's a real pleasure to be here, connected to many parts of the world, hopefully. And so good day to everyone, morning for some, afternoon or evening, depending on where you are. So I have selected, we're not going to cover all the mesenchymal tumors of the kidney, but I have selected 10 cases that hopefully will give an idea of some of the most common mesenchymal tumors of the kidney, and then some other rare entities that have real clinical significance, where the differential diagnosis can be tricky. And I hopefully will provide some morphologic features to guide you on that diagnostic workup. So we go to the case 1, slide 1A, which is now on the screen. I'm going to make it full screen. So you see a section of a tumor that is fairly pink, and it has an area of fat, some blood vessels, and this area of very cellular tumor cells. And if we take a closer look, you're going to see that these cells are spindle. They have relatively moderate amount of cytoplasm. That cytoplasm is eosinophilic. In areas becomes a little bit more rounded, more epithelioid looking, and this eosinophilic cytoplasm has some characteristics. If you look at them, the cytoplasm is a little granular in areas and fibrillary in other areas, which is a very helpful feature in orienting your diagnosis. You can see more over here. You look at the cytoplasm, it has this sort of fibrillary morphology in it. This is something that is not seen in the main differential diagnosis, which is going to be smooth muscle tumors of the kidney, which can happen too. So this is an entity that is composed by these spindle cells, but then also another important factors are these vessels with very thick wall that are scattered through the lesion. And then the third component is this fat that we saw at low power right here, which is also another component of the lesion. So once we have the three component, the diagnosis is relatively easy, because this, we all know, is an angiomyolipoma. But I just wanted to give you a classic case first, so that you know that once you have the three components, blood vessels with thick walls, the spindle cell component, and the adipose tissue, then you are almost certain that this is a angiomyolipoma, which is a benign tumor of the kidney that is fairly frequent. Now, it's not free of some diagnostic pitfalls. Some of the questions that can arise in these tumors are related to nuclear atypia. You're going to see some spindle cell lipomas that are, angiomyolipomas that have fairly good amount of nuclear TPA, and that has no clinical significance. Other things that are going to be tricky are the epithelioid AMLs, and the epithelioid AMLs can mimic a renal cell carcinoma. Now, AMLs are consistently negative for Paxate, and the majority of renal cell carcinomas will be Paxate positive. So that would be a helpful immunohistochemistry for the differential diagnosis. Another helpful immunohistochemistry stain would be cathepsin K. Traditionally, we know that AMLs are positive for melanocytic markers, HMB45 or melan-A. However, these are more commonly focal and often difficult to appreciate in a given section. But cathepsin K is usually diffusely positive and would be very helpful. Now, in epithelioid AMLs, cathepsin K is not enough to arrive at the diagnosis, because the differential diagnosis with renal cell carcinoma is real in those situations, and translocations RCC, specifically the 611 translocation RCC, it's also positive for diffuse cathepsin K. It can also, that translocation RCC, be negative for Paxate. So in those situations, molecular studies might be indicated to arrive at the right diagnosis. If you were to have an epithelial morphology, which you don't have in this case, then the differential with a renal cell carcinoma or with an epithelioid AML is the important thing. But then if you arrive at the diagnosis of epithelioid AML, then you have to look for the criteria for malignancy. Some of those can be malignant, and they're usually diffusely epithelioid in morphology, more than 70%. They usually have more than 2 mitosis per 10 high power field, atypical mitosis or necrosis. And if you have 3 of those features, the majority of the cases will be, we have a poor outcome. If you have a question whether this is a AML and versus a smooth muscle tumor or leiomyoma, for example, then smooth muscle markers will not be helpful, because AML would be positive for Desmin or SMA, usually not as diffuse as a smooth muscle tumor. So the clue would be more of your findings in the cytoplasm. And also to remember, when you're going to call a smooth muscle tumor, that the differential is AML, and therefore you perform cathepsin K is typically negative for smooth muscle tumors. Another feature that could be helpful is that in AML, some of the tumor cells come right off the wall of the blood vessels. So you have to look for your blood vessels, and then you're going to see the same spindle cells with the fibrillary cytoplasm coming off the wall of the blood vessels. So those spindle cells with smooth muscle differentiation, are believed to be arising from blood vessels. So this is a fairly straightforward case. They get operated because they have a risk of bleeding into the abdomen, and that bleeding can be serious because of the large blood vessels that the tumor has. So they have to be resected. Now, the ones, if we go to the to 1B, you're going to see this same case in this lymph node. This is a periaortic lymph node. You see all the lymphoid tissue right here, and you see the same tumor cells involved in these lymph nodes. This is a finding that is known to happen and does not have any prognostic significance. So I thought it was interesting to include it so that you know that if you get a case with what someone called metastatic AML, don't call him metastatic AML, just call it with involvement of one perirenal lymph node. And this has no clinical significance that should be noted to the urologists. So if we go to the second case without any interruption, because this case is also similar to the previous one, but in this particular situation, it's the characteristic finding in this tumor is that there is no fat. And these are the cases that get biopsied. So these are the ones that can be tricky for you because the fact that they have no fat in them is what makes them suspicious for RCC. And these by images will be basically indistinguishable by the radiologist of AML versus renal cell carcinoma. So, but it still can see the features of AML where you have some spindling of the cells, and even though they had eosinophilic cytoplasm, it is more clear than what you would see in a smooth muscle tumor, and it has that fibrillary look in the cytoplasm, as you can see in all these areas. It still has the thick wall vessels that are very helpful in the differential. If we go to the third slide, which is also connected, and this can be a problem in the frozen section. This is the opposite example where it's a fat-rich AML. And in the frozen section, they might tell you it's a tumor, and you say, well, no, it's fat. And that is the trap. So in order for you have to remember that AMLs can be fat-rich. And in this situation, you go down in areas where you have blood vessels, and you try to identify similar tumor cells as you would see in AML. For example, right here, you take a look and you start seeing some of the cells, they have that fibrillary cytoplasm, and they're coming off right at the wall of the blood vessels. So the trap in the frozen section is to believe that this is all just retroperitoneal fat and that is not a tumor. But if you look again at the areas where you have blood vessels, you start seeing some of the spindle cells with a fibrillary cytoplasm, and that is the clue for you to arrive at the diagnosis of AML. So you have to look carefully for these areas. So again, same prognostic significance as, what is it? Sorry, what happened? This? Oh, same prognostic significance as the fat poor's AML. So the only caveat here is to confuse it with retroperitoneal regular fat. The other thing is to confuse some of the tumor cells that might be in between the fat as a typical lipocytes and think that it could be a retroperitoneal liposarcoma. If that is the question, maybe immunohistochemistry could help, although MDM2 would give in certain situations focal positivity and should be confirmed by molecular findings before making or establishing a diagnosis of a liposarcoma. But again, if you look carefully, the vessels will show some of the perivascular cells that have the same features as we saw in the other slides as angiomyolipoma. So with that, we warmed up with a relatively easy case. And then we go to next renal mass. This renal mass is composed, as you see, at low power by some dilated cystic areas and a lot of stroma in between. Now, one of the things that are relatively common in mesenchymal tumors of the kidney is that they grow in between the normal kidney ducts, and they generate certain hyperplasia or dilatation of the ducts. And sometimes those ducts are not part of the lesion. We all know cystic nephromas and MEST or mixed epithelial stromal tumors in the kidney as a known entity. Now they're all called MEST, and the cystic nephroma is more left as a term for the children cystic nephroma. So these are all within the MEST category. These tumors are characterized by the dilated cystic areas and surrounded by a thick amount of stroma. In this particular case, we are not seeing too much of a helpful finding. That is the grouping of spindle cells around the cysts, which is a helpful finding in needle biopsies. Once you have this excised, you can look at the stroma. The stroma is very bland, is quite fibrotic. So this one will not be a diagnostic challenge for MEST. You just call it mixed epithelial stroma tumor. Here you can see a little bit of that stroma. These are more common in women because that stroma is sensitive to hormonal stimulation, the RPR, and it's more common in women after the age of 50. It can be seen in some men who have been on some hormonal therapy, either for prostate cancer or for other reasons. But again, in the needle biopsy, the main problem is that we know that these masks have a preferential grouping of the stromal cells around the epithelium, which would be a little bit like a phylloides type periepithelial cellularity. And remember that many other sarcomas that are not benign will have similar appearance. So in a needle biopsy, if your stroma is too cellular, that's where you have to pay attention. These are benign and they're cured with excision. If we go to, we're going to jump now from 4 to 10 because I want to show you the contrast. This is another case that was interpreted initially as cystic nephroma, but then this is the opposite situation. If you look at the amount of stroma here is way too dense, too cellular, quite monotonous in their morphology, in the cellularity, and this in a needle biopsy can be confused as a mass due to that ovarian-like stroma surrounding the epithelial cysts. You can see the cysts here have some hobnailing and enlargement of the cells, but are known to be reactive to the stroma, and they're not part of the neoplasia. And this is an example of a synovial sarcoma primary to the kidney that most commonly are of monophasic sarcomas. So take-home message, a lot of these stromal tumors of the kidney have associated dilated cysts that are entrapped within the tumor that are not part of the neoplastic process. Main pitfall in the diagnosis would be to confuse them with a MEST and disregard the cellularity of the stroma around the cysts as being ovarian type stroma. But if you look at this, this is way too much, and you're going to see mitotic activity. You're not going to see pleomorphism, and you're not going to see prominent nucleoli, and that can be wrongly interpreted as a bland finding in a small needle biopsy. But when you start looking at the whole section, you will see good amount of mitotic activity, and this should be worked up for a synovial sarcoma and perform molecular studies to confirm either of the two common translocation. So any relevant questions so far?
Not yet.
Okay, so we're gonna move on now. We were on case 4. We're going to do now case 5. This is another kidney mass that at low power you're going to see it's a little bit heterogeneous. Here's some thin vasculature that you see right here and there, some spindle cells, some more spindle cells here, and then you have this sort of more epithelioid foamy cells with clear cytoplasm that can, in a kidney mass, be interpreted as clear cell renal cell carcinoma. But it's not a clear cell renal cell carcinoma because we are talking about mesenchymal tumors of the kidney now. But if you look at the vasculature, it's way too much. It's even more than what you would see in a clear cell renal cell carcinoma. You have to look around a little more, and if you don't think about this entity, you're probably not going to diagnose it because it's quite rare in the kidney. But let me see if I find some areas that will be of good diagnostic clue. Right, so these are the areas you have to start wondering what's going on right here. You have the vessels, but then definitely you have some cells in between that have this foamy cytoplasm that look more like macrophages. So all that together with the thin, delicate network of blood vessels this should lead you to think that this is a hemangioblastoma. Hemangioblastomas are also VHL mutant tumors, so they can happen in the kidney due to the specific VHL susceptibility in the kidney. However, it's not the most common site, it's not the most common kidney tumor, and they're not associated with VHL syndromes in the kidney. So none of the cases reported so far were found to be VHL patients. So these are mostly sporadic. The main diagnostic pitfall here would be to think that this is a clear cell RCC. And the differential diagnosis can be easily achieved by immunohistochemistry, not by performing PAX8, because both can be positive. But if you do not think about hemangioblastoma, you're not going to do inhibin, for example, to prove that this is a hemangioblastoma. So key to this is the rich vascular network, some spindle cells, and the foamy histiocyte-like cells in between that are inhibin positive. Again, these are not syndromic. You should not make any comment that these are VHL related. None of the cases so far have been VHL related. They happen in VHL patients, but not in the kidney, more in the cerebellum. Other markers that are positive in hemangioblastoma include NSE, S100, and remember that PAX8 is also positive. We go to the next case. This is another kidney tumor, and this is a frequent situation, relatively frequent with the other stromal tumors of the kidney, where what you see now is a high-grade tumor composed of a lot of small, round blue cells. So now your differential has to be small, round blue cell tumors, and therefore it should include lymphoma, rhabdomyosarcoma, Ewing's sarcoma, and others. So once you identify this, you just have to think about a sarcoma as opposed to going down the line of just small cell carcinoma or an epithelial origin of tumor. So PNETs and Ewing's are relatively common in this group of small round blue cells in the kidney, probably equally or even more common than synovial sarcoma, which would be one in the differential diagnosis. Diagnostic clues are if you find pseudorosettes, which you don't see here too many. And the other thing is sometimes you're going to see some areas where they have a two type of cells population, as you see right here, where they seem that some of the cells are more blue and some others have some clearing and some of them are small. But this is a very soft finding. You still have to consider the entire spectrum of differential diagnosis with small blue cell tumor. It's a high-grade tumor. You see all this necrosis. They can have an aggressive clinical course. They happen in children. They happen in adults. It can happen in any age. So once you have done your differential diagnosis immunohistochemistry workup, you're going to end up with a combination of positive and negative stains. Negative stains that you should consider are myogenic for rhabdomyosarcoma, CD99. You can do keratin stains to rule out small cell carcinoma, neuroendocrine markers. Neither of the immunohistochemistry findings is going to be specific of Ewing's sarcoma or PNET, and you will have to do molecular to prove it. CD99 positivity in itself is obviously not sufficient. There are many other small blue cell tumors that can be primary, that are well documented in the kidney, that are CD99 positive. For example, lymphoblastic lymphoma, Merkel cell carcinoma, small cell carcinoma, rhabdomyosarcoma, desmoplastic small round blue cell tumor, small cell osteosarcoma, mesenchymal chondrosarcoma, melanoma. 60% of melanomas are CD99 positive. So CD99 could be a clue, but it's not going to be sufficient. The other marker that you could do is NKX 2.2, which is very sensitive and more specific than CD99, but is again not entirely or 100% specific. So then you have to go to molecular testing. And molecular testing will be performed to include translocations or fusions of EWS with different partners. So the partners that are more common is with FLI1. Now, there are other alternatives, translocations that might not be positive depending on the test that you use. So you do have to be aware that that all the other variants have been testing. Luckily, these translocations are relatively easy to remember, all the alternative translocations, because they're all with E or F. So you're going to have EWS with ETV1, EWS with ETV4, with FEB, and then you have an alternative fusion that's going to be with FUS, but again, with others that have E as ERG, for example. So E and F are the names of the genes, the first letters of the genes that participate in Ewing's PNET sarcoma. So that's a good way to remember it for your boards if you have multiple options to choose from. And then if any of them are negative, then you're stuck with the situation that now there is a growing body of literature in Ewing's sarcoma-like or Ewing's-like sarcomas. And in the kidney now, there has been well-documented 2 different other types, the sick rearranged sarcomas and the B-core CCMB3 sarcomas, where there are already papers for both types of well-documented primary to the tumor, to the kidney. And there is another paper coming out with 4 new cases of sick rearranged sarcomas in the kidney. And the partners are DUX or FOX, or even one case has partnered with NUT or NUT and has been positive also by immunohistochemistry for NUT. Sick ducts sarcoma or B-core CCMB3 sarcoma are the ones reported negative for NKX 2.2. So in the past, when these were negative, they were still called Ewing's like sarcomas. Now we have additional markers, so you could do B-core immunohistochemistry, which would be positive, or even CCMB3 that has a little bit more challenges in immunohistochemistry, but can also be positive. So with that, we're going to move out of this small. The other thing is I was going to say is that also with the molecular is not 100% diagnostic. So you do have to put together the immunohistochemistry profile with the molecular, because of EWS being another frequent gene that is affected in other small blue cell tumors, for example, the desmoplastic small round blue cell tumors. So you also need to include desmin or other markers of keratin to make sure it's not a desmoplastic small round blue cell tumor. So you had to put both together. Neither the immunohistochemistry nor the molecular could be 100% specific. Okay, we move on now to case number 7. This is another kidney mass, and if we take a low power view, you see it's quite homogeneously composed of a mixture of spindle cells and a lot of inflammatory cells in between. So let's look around, and they all have all these myofibroblast cells with very delicate projections of the cytoplasm and very prominent inflammatory background everywhere. A lot of chronic inflammation, but in some areas you're also going to see neutrophils. And if you look at the spindle cells, they have very small nuclei. There is not much, there is no areas of hypercellularity. So when you have this sort of stellate-shaped spindle cells with some eosinophilic projections on them, this myofibroblastic look to it, some areas of a lot of inflammation with plasma cells, a lot of neutrophils, some areas that have this myxoid background. But you could see some mitosis, but there's not going to be a typical mitosis. But everywhere you go, you have all this very prominent inflammatory infiltrate. So this is typical for IMT, regardless of the site. So you have to think about IMT when you get this in the kidney, which can happen as well. Here you see more of that myxoid background. IMTs are not the most common in the kidney, but it could be tricky in a needle biopsy because you might have the difficulty to differentiate this from reactive stroma adjacent to a mass. So if you had a needle biopsy, you probably would have to be descriptive and say that similar findings can be seen adjacent to the mass. But if it's representative of the entire lesion, then it's most consistent with an inflammatory myofibroblastic tumor. In that situation, ALK immunohistochemistry might be helpful, although it's not positive in 100% of the cases, but diffuse positivity for ALK will favor that this process is an IMT. Once you have a resection of the kidney, ALK has little utility unless you have a strong suspicion that this could be something else. But because I say so, because a negative ALK would not exclude an IMT. So once you have it excised, if you have a question about the diagnosis, the best approach would be to sample it more if it was really large and make sure that there is no other areas, there is no hypercellularity or areas that were, it could be, all this could be reactive to an adjacent mass. So if we go now to the next case, this here is another kidney tumor that, again, as we saw in MEST and we saw in synovial sarcoma, we can appreciate that the tumor is composed by two elements, the spindle cell element and the epithelial elements. The epithelial elements in areas has some dilatation, maybe a hint of some proliferation, so it can be a little bit proliferative. Just remember, this doesn't mean that the tumor is biphasic. This is a common finding. In any stromal lesion of the kidney that can have entrapped tubules. Now, when you look at the spindle cells here, they are clearly low grade. There's no pleomorphism, but it's too cellular. I have seen some of these where the question is, there are not that many reported of this in the kidney, but the question here could be medullary fibroma. Now, medullary fibroma is much less cellular than this. So the fact that this is so cellular should raise the concern of a low-grade sarcoma. Now, there is a spectrum of finding in these lesions. This is a, you can see here, you can see here in some areas that the stroma becomes a little bit more loose. In some areas, the cells the cellularity has increased. And in some areas, the stroma can be a little bit myxoid. So this is a low-grade spindle cell lesion in the kidney. And now your differentiator has to start thinking about something that does not happen in the kidney. So if you have a small, a low-grade sarcoma outside of the kidney, then one of the things that you have to think about is, could this be a low-grade fibromyxoid sarcoma? Now, it does not have all the features of a low-grade fibromyxoid sarcoma, but remember that that entity also overlaps significantly with sclerosing epithelioid fibrosarcoma. And this is what eventually this case turned out to be. Now, the key feature here is not to know the right diagnosis at first glance, but it's not to, the important thing is not to think that this could be a medullary fibroma. It's just too cellular. If you are in that pathway, then you would think about low-grade fibromyxoid sarcoma or sclerosing epithelial fibrosarcoma if you have some areas with more prominent sclerosis, which you can start seeing here. If you look at the cells, some of them will have some clearing around them, but it's very difficult to appreciate in this particular case. But you see some areas right here. And then the prominent sclerosis will happen in some of the areas. Alternatively, you could think that this could be a solitary fibrous tumor, and then immunohistochemistry will be helpful. these tumors are usually diffusive positive for MUC4. And then once you think about this entity, sclerosing epithelial fibrosarc, then you will need to do the molecular testing to prove it, and they have ESWR1 fusion with CREB3L1. So this fusion is present in the majority of them. The alternative FUS partner is also present in a subset of them, and that is the most commonly seen in the variant or the other spectrum, the less cellular and less fibrotic. There is the low-grade fibromyxoid sarcoma. So there are 2 cases primary to the kidney reported so far, and this is one of them. They are malignant, so the differential diagnosis with a benign spindle cell lesion is very important, because these have a tendency to metastasize, and they can get metastasis fairly late after the diagnosis. And this is the same case in a recurrence, where you see that now you see these cells with the clearing around, which is more obvious in this particular section. And now the MET is present in the kidney. So this is several years after the initial diagnosis of the other kidney mass. As you can see right here, you can appreciate some of the myxoid background, and still the low-grade cellularity with that clearing around them, and the myxoid background should be the hint for the right diagnosis. But this is the recurrence of that patient. You see the liver right here, where it came back and invaded the liver. So, and then we go back, we already did the last case briefly with the synovial sarcoma. Now this case had been called MEST initially, but later on it presented with recurrence in the stump of the renal vein, and it gave metastasis. So it was misdiagnosed and thought to be a MEST, but this degree of cellularity in the stroma is too much. So overall, we have covered as a spectrum of benign and some malignant stromal tumors to the kidney. Many of them have similar findings as outside of the kidney. The key is to remember that they can happen in the kidney. Also, it's important to remember that they entrapped renal tubules, and that that not everything that are tubules surrounded by spindle cells are going to be benign mests. And you do have to carefully look at that stroma to be able to diagnose a sarcoma. And then finally, remember that hemangioblastoma, although it's uncommon, it can be a pitfall with clear cell renal cell carcinoma, and is a benign entity that should be cured by excision, and is usually not associated with VHL, although they have VHL mutation in their pathogenesis, is not associated with the syndrome. So I think that with this, I'm going to be available for the last 10-15 minutes to answer questions or address any comments. Rifa?
Yeah, thank you, Dr. Matoso, for this very comprehensive discussion on the mesenchymal tumors. We have one question coming from Daniela from St. Louis University. She is asking for case 7, sclerosing epithelial fibrosarcoma. Could you expand on the idea of thinking about a lesion coming from outside the kidney?
Right. So this is the sclerosing epithelial fibrosarcoma is this one, and this tumor it was proved to be primary to the kidney. The patient did not have any other lesions anywhere else. So they, of course, the differential is like anything else. Could it be coming from the kidney? And this case was proved not to have a lesion anywhere else. So that's why they were called the primary kidney tumors.
And so another gentleman, Geronimo from Brazil, he has a request for you that he would be happy if you can list all the diagnoses at the right now, that what was the diagnosis for case 1. So,
oh, sure, we can do that afterwards and
okay,
make it available.
Yeah. So I think those are the questions that I can see right now. Let me see if there are any more questions. That's what I can see for now. But we'll be very happy to hear that
Yes,
we
so
have
you can
so many viewers from different countries. So I could at least list 18 different countries. So
amazing.
that viewers had
I'm very happy.
viewed this lecture.
Yes,
So thanks
excellent.
everyone for joining us. So
Yeah.
thank you for your time and
Thank you.
explaining everything.
Thank you. Thank you. I hope
Over
it's
to you.
helpful.
Thank you so much. Over to Emilio.
All right, thank you very much, Dr. Matoso, for that exciting overview of mesenchymal kidney tumors. Your digital slides were awesome, and I think our viewers probably greatly appreciated them. I think that's a great idea to post the diagnoses after the lecture. If you don't mind, we will gladly do that and add that to the Facebook video and YouTube video. So like Rifat said, it does not appear that we have any more questions at the moment, but remember, we can continue to have a conversation on Facebook by posting directly to this video once it has been archived. Up next, we're going to host Dr. Fausto Rodriguez, and he'll present on surgical neuropathology pearls, and that's Wednesday, May 16. And starting on the 21st of May, Dr. Lester D.R. Thompson will kick off a 3-part head and neck pathology series with his first talk titled, Who's New in Sinonasal Tract Pathology? So today's lecture can be found at pathologycast.com. If you enjoyed the session, please make sure to subscribe to our YouTube channel and follow our Facebook page. With that, until next time, thank you.